Good morning, everyone. Welcome to Grand Rounds. It is Wednesday, so therefore Grand Rounds. It's a pleasure to introduce Dr. Cannon. Dr. Cannon is a Milwaukee native, right? And then went to medical school here at UW. And despite our best efforts to recruit her to stay here at UW for training, I think she got confused with the UW and the UW and went to the West Coast to Seattle for her residency and her fellowship at University of Washington and Seattle Children's Hospital. But we were super excited to recruit her back here to Madison, where she joined the faculty, I believe, 2021, if I recall correctly, as an assistant professor on the CHS track here in our department. She's also the director of DEI in our department and is the site director at the AFCH for our residents. And is going to be presenting to us this morning about prenatal hydro. Without further ado, Dr. Cannon.
Yes, thank you. And good morning, everyone. I wanted to really focus on a subject that I think is, kind of right in front of us all the time, but doesn't get a lot of kind of specific attention. Prenatal hydronephrosis is very common. And for those of you who attended the Wisconsin Urological Society meeting this weekend, you heard from one of the nurse practitioners in our division about, just how common it is and, why we need to think about it more. But I wanted to just focus on kind of the big picture in the area of hydronephrosis for infants and children and what we do with that diagnosis. So we'll be discussing the epidemiology and classification of prenatal hydronephrosis. We'll also be describing potential causes of prenatal hydronephrosis. And then finally, we'll highlight some innovations, and I'll spend a brief amount of time looking at both kind of predictive management and surgical management in that area. So as I said, hydronephrosis is very common. It occurs in 1 to 2% of all pregnancies, and about 40 to 80,000 births a year will be, with an infant that had a diagnosis of prenatal hydronephrosis. And this is expensive. It costs about $90 million annually in the United States alone for management, both before and after birth. And that's, through a variety of sources. That's, visits, ultrasounds, additional diagnostic testing. All of this is to try to get to the bottom of the diagnosis and understand, how closely a patient needs to be managed. So when is prenatal hydronephrosis detected? It's detected about midway through a pregnancy. So urine production begins at around 14 weeks. And most pregnant women undergo an anatomy scan around 20 weeks. That's like the midway point of pregnancy. And that's usually when hydronephrosis is first detected. Occasionally, in very severe cases, it can be detected earlier than this, but that's usually the first ultrasound where mothers are getting the diagnosis. And that diagnosis can change over the course of pregnancy. So depending on the severity of the hydronephrosis, a woman may undergo additional ultrasounds, like on a monthly basis, occasionally on a weekly basis, again, if it's very severe. And sometimes that diagnosis can worsen, meaning the hydronephrosis gets worse on the ultrasound, or it can improve. But, in most cases, it does remain stable. And what we see on the prenatal ultrasound is what we end up seeing postnatally. Some additional radiographic radiologic features that suggest severity of hydronephrosis in pregnancy: oligohydramnios, meaning that the amniotic fluid levels are low, poor cortical medullary differentiation, the kidneys are poorly defined on the ultrasound, increased echogenicity of the kidneys, and then renal cysts. Those are not associated with particularly good outcomes after birth. So, those are things that can aid with counseling of mothers about their babies prenatally. So, like Dr. Farhat said last week, embryology, it's like people's eyes kind of glaze over when you talk about it. So just to briefly say that there's, I think critical points at which renal development takes place. This all starts actually at about 4 weeks of age. where the kind of protonephrons or the pronephros starts developing. There's three phases: the pronephros, the mesonephros, and the metanephros. And then that finally, around 12 weeks of age is, the final component of kidney development, where we see that last phase of renal development really become the dominant one and turn into kidneys. And the kidney tissue is coming from a different embryologic structure than the ureteric tissue. So you can see here that the ureteric bud actually interacts with the mesonephric, the metanephrogenic blastema at the top there. And I'm trying to see if my mouse can work. So this kind of part B is where you start to see those interactions, the ureteric bud and the kind of the proto-calyceal structures start to divide, and they divide multiple times until they get to be nephrons in the millions. So you have the ureter and the nephrons all coming from the same structure. And then this is just to show that over time, the kidneys ascend into their final position, and that ascent does take, probably about half the pregnancy to get into the final position. And ultimately, those positional movements do influence the risk for hydronephrosis in some children. So anatomic anomalies of kidney positioning can lead to hydronephrosis diagnoses. So I want to just really emphasize that hydronephrosis is an imaging finding. It is a diagnosis. Obviously, we are making that diagnosis prenatally for infants who are being detected on prenatal ultrasound, but that doesn't actually give us the underlying etiology of the hydronephrosis. It's just dilation on the ultrasound. We can make an educated guess about the etiology of the hydronephrosis, but that is not guaranteed, and ultrasounds alone don't give us that information. So this is a list of the differential diagnosis of hydronephrosis. I think the biggest thing to call to you is that the top line is transient or physiologic, and that occurs, in 50 to 70% of diagnoses. And then after that, the next most common are UPJ obstruction, vesicoureteral reflux, and a little less common UVJ obstruction or megaureter. And then the ones underneath it are really a lot less common. And so, this is how I counsel families when I see a prenatal diagnosis patient. There's kind of three big buckets. Hydronephrosis could mean that the baby has reflux. It could mean an obstruction. And I like to describe it like a traffic jam or a bottleneck where the urine's trying to get through a tight space and it gets stuck there. And then there's transient, and that's most patients. And I don't know why. It's just, they have it and hopefully they'll go away. But that differential diagnosis, those buckets I tell families about varies by severity. So we know that when we see prenatal diagnosis or prenatal hydronephrosis that's mild, it's most likely to be that transient diagnosis. But for those who are moderate or severe, there's increasing likelihood that ureteropelvic junction obstruction or vesicoureteral reflux will increase. And in severe cases, it's more likely to be an underlying anatomic anomaly. So calling to you, when you look at the severe category over here, you see UPJ obstruction being most common, and vesicoureteral reflux is actually the most common, or the second most common for moderate. So, maybe if you see a really severe dilation, you think more of UPJ obstruction, and somewhere in the middle, it may be a little less clear. But even with moderate, you can see that about 55% is transient, and severe is 12%. So, there's still possibilities for these diagnoses to improve with time. And mild is actually most common in all pregnancies. So that's always a nice thing to know, that, when you see parents in a prenatal visit, you can give them potentially a fair amount of hope that this is going to be something that their child does not need surgery or aggressive intervention for. This gets to then, well, if we're trying to differentiate between those patients who have, the severe hydronephrosis, we need to be more, more investigative for, or the hydronephrosis that is most likely to be transient. How do we determine that severity? And that's where we get to the grading systems. Grading systems, there's many of them, and then there's actually more than I will be showing you today in this talk. But the key features for most classification systems are the anterior, posterior renal pelvis diameter. So that's when you're visualizing in the fetus, you would have a nice abdominal circumference view. That's when they're kind of measuring the abdominal circumference of the fetus. You can also see then the trans view of the kidneys, and that's where they'd measure that AP diameter. The renal pelvis, calyceal dilation, renal parenchymal changes, and lower urinary tract findings are all key components of classification systems. The main three systems that we usually encounter in a clinical setting are the APRPD, and that's just the renal pelvis diameter alone. And that's what is usually used by maternal fetal medicine specialists when they're doing these fetal ultrasounds. And then the Society of Fetal Urology, or SFU grading scale, is more common amongst radiologists and urologists. And then the urinary tract dilation system is a 6-point standard reporting system that includes lower urinary tract findings like the features of the bladder and the ureters, and the prenatal. It has a postnatal and prenatal grading system. So the APRPD grading system, again, like I said, used for the fetal urology or fetal ultrasound primarily. You can see that it actually has a shifting grading system. So there's a second trimester grading system and a third trimester grading system. And moderate or severe, I like to think of like a centimeter and 7 millimeters as kind of my like cutoff points. So over a centimeter is severe, and then under 7 millimeters is mild. And then for third trimester, those move up to 15 millimeters and 9 millimeters. The SFU grading system really focuses on the dilation of the renal pelvis and calyces. So you can see that this is an example of each of the grades where you have, basically just the renal pelvis for grade 1, a few calyces for grade 2, and then, all the way up to grade 3 where the renal parenchyma is thinned. And then when you compare that to the UTD grading system, the UTD grading system really kind of starts at SFU grade 2. The UTD grading system, again, has a prenatal and postnatal grading component. And so the prenatal grading system kind of includes those cutoffs that were mentioned in the, sorry, I'm having a hard time like moving the mouse here, trying to see if I can get it to show up. I don't know if I can. Oh, here we go. Okay, so prenatal grading system, we have a split point, essentially the same as the APRPD, looking at the severity for the renal pelvis diameter before and after the kind of third trimester start period. But then these also include the ureter and the bladder. So any abnormality of the ureters or the bladder is considered, if it's abnormal, that bumps a fetal diagnosis up to UTD A23 or increased risk. And that implies that you would follow them a little bit more closely after they're born. And then these are some pictures of what it actually looks like. So this was the ultrasound description that I was telling you about. This is a fetal ultrasound. This circular thing is actually the whole abdominal circumference. You have in the back, this is the spinal cord right here in the vertebrae and the erector spinae muscles. And then these black circles are the APRPD. So that's what they're measuring. This long view gives us the image of the renal pelvis. And then these are the A2 and A3 diagnoses where you see these renal pelvis diameters are much wider. You see renal calyces that are more prominent. And then in this figure at the bottom, you can actually see the ureter dilated in the fetus. So postnatal diagnosis kind of carries similar kind of bump up criteria. You have these, later development APRPD classifications. And then when the ureter is abnormal, it gets bumped up to P2. And if there's any parenchymal abnormality or bladder abnormality, it gets bumped up to P3. And this is a picture of kind of postnatal diagnosis of P1. Here's, an example of central calyceal dilation, but not extending into the periphery. And then P2, you have, these broader dilation areas. Peripheral calyceal dilation is a little bit more prominent. And then finally, you have here some parenchymal abnormalities for P3, a renal cyst, some parenchymal thinning, and then this bladder wall thickness that you see in the third image. So which grading system is best? I think that is actually a significant point of debate amongst pediatric urologists, radiologists, and MFMs, and probably nephrologists too. I think they're also included in this group of people who really rely on grading systems to try to understand patients and how to best manage them. So for both SFU grading and UTD grading, there is actually literature that shows that there's good inter and intra-rater reliability. Inter-rater meaning between two different raters, they agree if they look at the same picture, and intra-rater reliability meaning the same person looks at pictures and kind of is consistent with their own internal rating system. It is in some literature SFU is slightly better, but it's not clear that it's clinically significant because they're both actually quite reliable. The ureteral dilation and bladder abnormalities are a key feature of the UTD grading system, but it's not clear what to do if you have ureteral dilation or bladder abnormalities, but there's no dilation present in the renal component. The communication of risk and the rationale for management decisions is not really clear, even with kind of the acceptable reliability of these imaging or severity grading systems. And ultimately, when you have this intermediate severity group of patients, this reliability is still the worst. So that's where we need it the most. We need to be able to determine the patients who are in the middle, who might have a better course versus who may progress to a worse course. And those are really the patients who we just don't understand how we can best counsel them. So how do we manage prenatal hydronephrosis? I think these are questions that we ask ourselves, and that there are questions that we ask ourselves, and there are questions that parents ask us. For ourselves, we ask, will this require surveillance and monitoring? Will this require further diagnostic testing? Will this require medical management, or will this require surgical management? And the questions parents ask, encompass many of what we're thinking, questions we're thinking and asking ourselves, but they're kind of big picture questions. What's next? What does this mean for my baby? Will my baby need surgery? And I've certainly had in many prenatal counseling, even for very mild cases, will my baby need dialysis? Will my baby need a kidney transplant? A lot of parents are kind of going to the worst case scenario when you tell them that something is wrong with their baby's kidneys. So when we look at prenatal management, we think of the goals. There's, how often are we surveilling the fetus? Because that means that a mom is coming in weekly or monthly for these ultrasounds. There's, as Jenica had discussed in her presentation, a lot of stress that revolves around really close management and ultrasounds in pregnancy. We are also looking for opportunities for fetal intervention, especially for patients with LUDO, or lower urinary tract obstruction. Those are the patients with kind of the most severe presentations of hydronephrosis. We're wondering, do they need early delivery due to oleohydramnios or anhydramnios? We're thinking about, do they need a fetal intervention, vesicoamniotic shunt, or fetal cystoscopy, with valve ablation potentially. And then we're also trying to establish a postnatal imaging plan. So when do they need to get an ultrasound? Do they need to get additional imaging right after birth? And then appropriate counseling, again, answering those questions that moms have. When I show you this is like the UTD recommendations based on risk stratification, and they're still pretty like broad-based. They don't give a lot of guidance. So there's a lot to be done in terms of research and kind of quality improvement in this field to try to understand how we can best help families, particularly those with moderate cases of hydronephrosis, because we kind of have good data on what to do with ludo and how aggressively to manage those patients. We know that for mild, it's likely going to be watching, but for the intermediate group, what do we do? The goals for postnatal management, again, risk stratify. We're trying to identify patients who are at higher risk of UTI, patients who have a higher risk of renal deterioration, or those who may need to go on to have surgery. And then also looking for early diagnostic evaluation, who's going to need a VCUG soon after birth, who's going to need, evaluation for obstruction, and then those who need early intervention. And I just want to call out, I think this is, something the residents in our clinic have probably heard before, but I think I go to most prenatal visits by video, so a lot of times you don't join me for those. A postnatal ultrasound should be performed, with the exception of those with really severe concern for ludo. It should be performed after 48 hours of life. And that's because, the baby is intravascularly volume deplete after birth, and that can underestimate hydronephrosis. And, that's something where maybe a newborn nursery or an outpatient primary care provider may get an ultrasound early, say it looks great, and then tell the family to move on, and maybe it actually would have worsened and required some additional surveillance later. So again, this is the UTD system. They do provide both prenatal and postnatal management guidelines or recommendations, but there's a lot of portions here that you can see, say, discretion of clinician. So there's not a lot of guidance out there that's kind of standardized. And I think that's also due to the fact that there's a lot of lack of consensus over severity grading systems and what to do with those pieces of information. Okay, so what do we do for transient or physiologic hydronephrosis? Again, I said it can resolve in about 20 to 50% of cases, and that can actually be a great thing to tell moms in the prenatal period, that if they get another ultrasound, it actually may go away before the baby is born. But postnatal resolution rates are also really high. So SFU grade 1 has a 100% resolution rate at around 26 by 26 months. And that is really kind of the reason why SFU grade 1 was shifted to UTD 0 because they saw such a high resolution rate in those groups. So for UTD severity, the SFU doesn't even really get a grade. SFU grade 1 doesn't get a grade. And I would say this kind of goes, this bottom component, bottom bullet point goes back to my first initial slide saying hydronephrosis is not a diagnosis that gives us etiology. So yes, there's increasing risk of vesicoureteral reflux with increasing severity of hydronephrosis, but vesicoureteral reflux can be present without any hydronephrosis at all. And so it can be present and go undiagnosed. It doesn't really correlate well. UPJ obstruction can be caused by several components. It can be due to intrinsic narrowing. That's what we see most commonly in infants. It's like usually an aperistaltic segment that prevents urine from moving from the renal pelvis into the ureter. Accessory crossing vessel, that's what you see in this bottom figure, where the lower pole of the kidney has a secondary vessel that provides blood supply, and that has caused a hang-up point for the ureter, and that is kinked. We most often see those in older children, but obviously they were always there to begin with. So, for infants, that can be a potential cause as well. And then sometimes it can be secondary to ureteral kinking. We see that a little bit more often in infants who have maybe a component of reflux as well, that eventually there's enough dilation and tortuosity of the ureter that it causes a secondary kink at the UPJ. About a third of patients will need surgery, and the indications for surgery are increasing hydronephrosis, decreasing renal function, particularly in the affected kidney, breakthrough UTIs while on antibiotics, and symptoms, and that's particularly in older children with flank pain and Dietl's crises. We use MAG3 to diagnose these. I think most of you have seen a MAG3 in our clinic. It doesn't look like this, but I think the big key feature is this is one, a radiopharmaceutical medication that's being injected by IV, getting picked up by the kidneys, and then being processed through the urinary tract. So our patients get, for babies particularly, get a catheter so that it gets out of the body as quickly as possible. And then we look for differential drainage of each of the renal units. You can see that curve on the top where the left kidney is not draining well. And so the curve kind of remains elevated. That correlates with if you're looking at these kind of picture by picture views. So the top pictures show that the kidneys have picked up the medicine quickly, but really by the end, the left one only has medicine remaining in it, and that indicates obstruction. Dismembered pyeloplasty is the most common procedure we do for this obstruction. And you can see that it really doesn't vary significantly if there's an aperistaltic segment that's narrowed or intrinsic narrowing or a crossing vessel. This dismemberment is pretty similar where we will incise the pelvis, spatulate the ureter so that it's wider open, and then anastomose these back together. And the difference for a crossing vessel is this is brought in front of the crossing vessel, so it's no longer obstructing the ureter. Vesicoureteral reflux, again, the third most common. It's caused by retrograde flow from the bladder to the upper urinary tract. There's two different types of reflux. I think the one that we see in infancy is most often this primary reflux. So that's a congenital defect of the ureteral vesical junction. You can see in this figure, the ureter is supposed to tunnel all the way down to its orthotopic position. But if it doesn't tunnel enough, then that tunnel is too short, and that allows more urine to reflux up. So a very short tunnel will lead to reflux. Maybe there's some reflux if it's not quite making the mark. Secondary reflux is due to intravesical pressure. And so we can sometimes see that early in infancy if there's discoordinated kind of bladder and sphincter functionality. So the bladder is trying to squeeze to empty, but the sphincter is not coordinated with it. That increased pressure can lead to reflux, but most often we're seeing an anatomic contributor to reflux as the primary source. It's really complicated. You could do a whole talk about reflux alone and how to manage it. This weekend, Dr. Kirsch gave a really wonderful talk on reflux and the use of deflux in those patient populations and the indications to do anything for those patients. But primarily we think about renal function decline, renal cortical scarring, breakthrough UTIs while on antibiotic prophylaxis, and kind of the presence of bowel and bladder dysfunction as kind of all contributors to our decision to offer surgery. VCG is our primary diagnostic testing. And so, this is something that we can do right after birth. And we often do that for infants who are concerned for posterior urethral valves, but it also gives us information about reflux even that early in life. And there's a grading system. It's the International Classification System. That's grades 1 out of 5. And that helps us determine, how likely is this to resolve? How likely is this to need surgery? This is our images of kind of lower grade reflux. We have right grade 1 or grade 2, and then left grade 3, where there's a little bit of dilation of the urinary system. Grade 3 and above is considered dilating. And then you can see this severe grade 5 with tortuosity and blunting of the calyces. And I just want to call out, there's other ways to diagnose reflux. We just don't use them as commonly. So radionuclide cystography is an option that's kind of using one of these radiopharmaceuticals, kind of similar to a MAG3, but it's really just looking at where that medicine goes within the bladder. And then CVIS, or contrast enhanced voiding ultrasonography, is a newer technology, but is nice. It's nice to offer because it doesn't involve any radiation, but it still requires a catheter. All of these things require some invasiveness to diagnose. So again, management for VUR is complicated. There's a lot of different variables that play into the decision for whether or not to treat. We think about postnatal scarring, renal function, how to make sure a patient has a reduction in UTIs. And we think about, do we want to, are we able to treat this medically or kind of stabilize the patient medically? We think about antibiotic prophylaxis and reduction of bowel and bladder dysfunction. And then do we need to think about surgery? And so the primary surgical management options are endoscopic bulking and surgical reimplantation. I put circumcision on there because that is, especially for male infants in the first year of life, a significant consideration because they're at a slightly greater risk of UTI in that time period. So circumcision can sometimes be an appropriate offering for a male infant with reflux. Here's some figures that show the different options for reflux surgery. I think that this one on the left, the intravesical approach, this is a Cohen cross-trigonal reimplantation, is the most common surgery, or kind of the historically gold standard surgery, although Dr. Kirsch's talk kind of brought some question to whether or not we should still consider that the gold standard. What you do here is you incise around the ureters, core them out, free them from their intramural tunnel, and then you actually extend the tunnel. And so, you know, these two, if I can get this to work, these two lines here and here are the old ureteral orifices, and these ureteral orifices have now been crossed across the trigone and have extended the tunnel in doing so. This is something that has like a 95 to 97% durability, meaning that there's a very low failure rate. But it does, you know, it's an open surgery, it requires opening the bladder. Many children recover very smoothly from this, but it is, there are a lot of symptoms involved with bladder surgery. Extravesical approaches are also used. This is showing the kind of the original bladder hiatus where the ureter is inserting into the bladder and incising the detrusor to extend the tunnel on the outside. I like this approach because I do think there is less bladder symptoms, especially in older children who need this approach. And then finally, this is endoscopic bulking. Deflux is the, you know, really the only game in town for this. I think there's some other bulking agents that could theoretically be used, but we don't typically use them. And this shows, you know, kind of you aim for the submucosal intra or almost intramuscular component of the ureter, and you really want to occlude the ureter in your endoscopic bulking. I'm going to just talk briefly about posterior urethral valves because I think that, you know, that's something that is of the severe fetal ultrasound or fetal hydronephrosis that we see. This is, you know, the most common diagnosis. This occurs only in male fetuses, and that's primarily because this is these posterior urethral valves are a residual urethral tissue that stays there instead of regressing in the course of male urethral development. The ultrasound findings, you'll see bilateral significant hydronephrosis and ureteral dilation. You'll see a thick-walled bladder because this is an outlet obstruction. So the bladder is working really hard to try to get urine out. A keyhole sign, which I'm showing here in this figure, it's really hard to see, but where this arrow is the kind of bladder neck. And this dilated area below the arrow or to the left of the arrow is the posterior urethra. It's dilated because the valves have created an obstruction distal to that part of the urethra. And that is a key. If you were like looking at a keyhole, the bladder is the big part of the key and the posterior urethra is the little part of the key. And then you may also see oligohydramnios, and the urine that comes out during development is being swallowed and inhaled, for lack of a better term, by the fetus. And so that's why this is a very severe diagnosis. If you see oligohydramnios, that baby may have issues with pulmonary hypoplasia. And that is usually, for the most severe cases of ludo, the primary mortality concerns is that fetal lung development is severely affected. So antenatally, we think about managing that with a vesicoamniotic shunt, and then cystoscopy and valve ablation. That's really specialized. How that is done is MFM will make a myotomy in the uterus, and then the baby will be positioned into an area where the belly or the abdomen is exposed, and then there's an incision made into the bladder, and then that's an antegrade cystoscopy through the bladder neck to the posterior urethral valves for a laser ablation of the valves. I know Dr. Bhatia has done maybe like a handful in her career, and it's a really technically challenging surgery. As you can imagine, it's a very small target. Posterior urethral valves can be imaged postnatally, and we have to do that. So VCUG is the primary imaging modality. You can also use voiding ultrasonography or contrast-enhanced voiding ultrasonography. Really, the management is the catheter is placed pretty soon after birth so we can start decompressing the bladder. Once the baby is stabilized, and that may be from a bladder standpoint or maybe from a lung standpoint, we get imaging. And then if we can, a cystoscopy with valve ablation. This picture is, kind of showing you those valves, and those two blue lines are where you'd incise the valves. And a vesicostomy is sometimes an alternative, particularly for a very small infant with inability to do an endoscopic upfront surgery and who's not doing well from a urinary standpoint. Other causes, a lot of other causes. So multicystic dysplastic kidney, ureterocele, megaureter, those are all, kind of different components that can contribute to this prenatal diagnosis, particularly in severe cases. Ectopic ureter, ureteral duplication, urethral atresia, prune belly syndrome. I could continue, but I will stop. So I wanted to just briefly talk about some innovations in the management of prenatal hydronephrosis. I think the big question mark in this field is, what do we tell families? Like we don't have consensus on grading. There's a lot of potential roads and pathways a patient could take, and we don't really have a great understanding of, based on that initial imaging and at the 20-week ultrasound, where this is going to go. So what if we could tell families with more accuracy who would need surgery? When is it okay to stop surveillance? That would be great. Predictive prognosis requires data, and it requires clean data. And I think that's, part of the problem is that we have all of these different classifications of hydronephrosis severity. We have different definitions of progression. Is it UTIs? How do we define a UTI? Criteria for worsening hydronephrosis. How much worsening is truly worsening? And then other clinical data, like hospitalizations, renal function, all of those things are not consensus. And when you add them up, you lead to, a hard time really understanding and studying patient pathways and outcomes. And I think the outcomes themselves are challenging. Trying to study something by its outcome, like who's getting surgery, that is kind of a cyclical argument. And so there's a lot of debate on whether surgery itself can be an outcome to study a diagnosis by. So predictive prognoses require large volume data, and there's some good opportunities out there. So the first is multi-institutional collaboration. So the Societies for Pediatric Urology has a hydronephrosis task force registry that used to be the Society of Fetal Urology Hydronephrosis Registry. It's kind of changed its name over the years. This is a prospectively enrolled registry from 10 different institutions and growing. It also includes us, which is very cool. There's over 2,300 patients in the registry, which sounds like a small number, but that's probably the largest collection outside of an administrative database that's ever been collected. For example, I presented on our cohort of ureteroseals, which we had about 114 in the registry a couple years ago, and now have about 150. That's the largest kind of series that's ever been reported. And so I think that's really important to know that this seems like a small number, certainly compared to other diagnoses we study in the world of urology, it's small, but this is actually the largest we have. The Pursuit Network is based in Colorado. They're doing a lot of work about standardization of EHR data so that we can collect data across multiple institutions and understand, these disease processes in a more efficient manner. So looking at how we can utilize or harness the EHR to ask the questions we need to get answers for. Artificial intelligence is, kind of a huge topic. Again, something you could spend a whole lecture talking about. This is an area that is really ripe for implementing artificial intelligence, but it's also really challenging primarily because of this kind of heterogeneous data that we end up collecting. We've been looking at kind of what's out there for artificial intelligence, and there's a lot of clinical data modeling, meaning we kind of enter patients' reports from their ultrasounds, their clinical demographic information into a model to try to predict who's going to go on to need surgery or who's going to go on to need medication or have progression. There's a lot of imaging artificial intelligence that really looks at the ultrasound. Can we follow ultrasounds over time and use parameters, imaging parameters, to understand who's progressing and who's not? The ideal model will combine that clinical and imaging data, and we don't have that right now. And so that's part of, some of the work that we're doing here is to really understand how we can create an idealized model that incorporates all the components of a patient's medical information to make some better decision support and prognostication. And then I just wanted to quickly, if I can, we'll see if I can do this, talk about surgical innovation. So, because I think obviously we're all surgeons and surgery is fun. So I just wanted to show you kind of some of the cool things that we've seen out there for treatment of hydronephrosis. And these are specifically for pyeloplasty. Let's see if I can turn this on.
We present a case of a single port robotic pyeloplasty in a pediatric patient. We describe the technique for a single 3-centimeter hidden incision. A 7-year-old boy presented to the emergency department with flank pain, nausea, and vomiting. He had experienced several similar episodes multiple times during the past year and a half. At the time, there was no concern for infection.
So I'm going to just fast
CT
forward.
abdomen and pelvis showed severe left hydronephrosis and a delayed nephrogram. MAG3 renogram showed left cortical retention and a 40% differential left renal function. The family was offered all available approaches to. We present a case of a single port robotic pyeloplasty in a pediatric patient. We describe the technique for a single 3-centimeter hidden incision. A 7-year-old boy presented to the emergency department with flank pain, nausea, and vomiting. He had experienced several similar episodes multiple times during the past year and a half. At the time, there was no concern for infection. CT abdomen and pelvis showed severe left hydronephrosis and a delayed nephrogram. MAG3 renogram showed left cortical retention and a 40% differential left renal function. Inferior fascial shells are made in the classic Phanestoe fashion. After the pyramidalis muscles are split in the midline, the prevesical space is developed and the incision is again retracted superiorly with the help of a long nasal speculum. As the bladder is decompressed, the peritoneal reflection over the dome of the bladder becomes evident and is sharply incised, then tagged to assist in closure at the end of the case. The SP cannula and tracer in ear left bottom. When assembling the gel point, we prefer to put the cannulas and tracers, including the rosy, through the gel seal cap prior to attaching the cap to the sleeve. We use rubber bands, shown here in orange, placed around the gel cap, insufflation ports, and the metal SP cannula to keep from accidentally pulling out the SP cannula from the gel point during the case. This is how the docked robot appears from the console. Similar to the XI robot, the SP cart can be brought in from a variety of angles to allow room for a bedside assistant. We emphasize a floating dock is used in pediatric patients to create distance between the top of the SP cannula and the target anatomy while still maintaining insufflation. The SP instruments require at least 10 centimeters working distance between the tip of the cannula and the target anatomy, so the arms can fan outward. In this setup, the robotic arms are actually exiting the robotic cannula before they enter the abdomen. To begin, with the camera within the floating dock, the tips of the instruments are brought within the incision and the abdomen and the arms fanned out. The camera can then be brought in. Once the camera is in the body, the entire floating dock can be elevated or burped away from the body using the robot's cart's boom clutch. This improves the working angles and operative perspective, and better allows the robotic camera to be positioned in a preferred cobra position. Therefore, we recommend making note of the camera's position using the instrument navigator and caution against protracting the camera.
And then this is even kind of a next iteration of that. So, the incision is very small for these, and you can see that this, figure F in the bottom right is the final incision, which is essentially like our orchiopexy or hydrocele hernia incision. It's very small, but this is an extraperitoneal single port pyeloplasty, with a hidden incision at the end. A really neat opportunity to consider the surgical future for these cases. We'll see, time will tell. So prenatal hydronephrosis is common. Its prognosis is uncertain. There's no consensus for the best option for hydronephrosis grading. Both SFU and UTD grading are reliable and have benefits, but they're not perfect. Hydronephrosis is often transient, but with increasing severity, it's less likely to be transient. Reflux or UPJ obstruction are more common. Innovations in predicting the course for patients with prenatal hydronephrosis and emerging techniques in surgical management can change our field. Time will tell. I don't know. So thank you.
Does this work? Oh, it is work. Cool. I have a question. Shannon, thank you. That was fantastic. I have to hold it. And I'm sorry I had to step out. I have two questions, one for you and then one for our endo specialist. Did I understand from the lecture this weekend that no matter what grade of reflux, even though grade is not what we're supposed to be using, we're supposed to be using our index, potentially, that Dr. Kirsch would do deflux for everybody first?
Actually, yeah.
And is that the approach here? That's my first question.
No, it's not. I don't think it's the approach here. I mean, I think it's something that we need to consider adopting. I think all of us have trained at institutions where that was not utilized in our training. And I think historically, when you think about the kind of percentage of, historically, when you look at the numbers, you see a really low rate of resolution for high-grade reflux with deflux. I think there's some changes to the technique. There's also some changes to like the approach to diagnosing, including the VUR index, that help us to make a better determination about like who might best benefit from endoscopic intervention for high grades of reflux.
And then we started doing deflux about 20 years ago now, I think because it was relatively new when I was training. Our endo folks now seeing these little kids with stones and really difficult to access ureters.
Yeah, I think, reimplants are difficult to access. And deflux can make it difficult to access too, particularly if it's calcified. We don't have a great, like, a great alternative. I think that, the extravesical approach is nice because it doesn't change the location of the ureteral orifice, but it's not ideal for many patients. Particularly, we think about there's good data, especially in the robotic approach to the extravesical reimplant. If you do that on both sides, you can increase the risk of urinary retention because you're getting into kind of maybe more of the nerve plexes. And that's, something that we try to avoid. So when we have bilateral, we're really thinking about that cross-trigonal approach. And so it's hard. We sometimes have to kind of re-stent a patient who has a cross-trigonal reimplant. And so it's worth trying rather than saying, okay, we're going to go to a nephrostomy tube automatically. But I think there is a higher risk that a re-intervention for the upper tract is going to need a nephrostomy or an antegrade stent placement. Yeah.
Just a real quick question about, so, in a lot of fields with rare diseases, there are these databases that are set up. It's good to, and I know that pediatric stomachs are we contributing to that data set? What's sort of the future with regard to that? It seems in pediatrics, there's a lot of, well, I did 7 of these.
Yeah.
Much more than in other diseases. Urologic entities.
Definitely. I mean, so, I'm the person from here that's part of that task force, that multi-institutional task force. And when I say it's like 10 institutions and growing, I think a lot of places are really recognizing, even though they have maybe they're a high volume center, it's not high volume enough to really make strong assessments of, what's good practice, what's better practice. And I think we are coming to terms with this growing prospective registry with a lot of disparate data, a lot of disparate practices. And, how can we best utilize this collaboration to research in a rigorous fashion? And so what we're trying to start envisioning is actually prospective interventional changes. These patients have been signed up with the idea that we're not going to change practice specifically for their care, but we are looking into the people we come to register down the line, enrolling them with the understanding that we may be trying some collaborative wide intervention standardization and seeing if that has an effect on the outcomes for our patients.
It's good to hear.
I feel like I'm testifying before Congress, these things. Just to echo what you said, congratulations on, we have the same problem in reconstruction. These are, relatively uncommon. They're managed very differently at different places. And so the answer is to pool data, which is not hard or not easy to do. And then I think ultimately, where is it going? Going towards, interventional prospective trials, right? So congratulations on that. And with the SP, maybe more of a question for Dr. Gerard, actually. Is there any discussion of getting an SP at the institution level? Yeah.
Great.
So we sort of got this, now we've got some sheets and that most everybody can be, finally we have enough that we can go around, and I think that's definitely in the docket. So, yeah, and just encourage, especially the junior faculty, get involved in these data sets. Provide a lot of academic material. So seek it out and get involved.
Thank you, everyone.
Shannon, I'm sorry, Shannon, I just had a comment and a question. Comment, not to go too far off the deep end of social commentary, but your slide about the burden of the prenatal hydro costing about 90 million a year in the US. Driving in this morning, heard on the radio that the Buffalo Bills quarterback signed a contract extension for $330 million. So yeah, that's just a little, food to chew on when we're thinking about just cost and, healthcare and everything. But my question is about the grade 1 and grade 2s that spontaneously resolve over time.
Yeah.
Do we have longitudinal data on those patients? Meaning, when do we know about those 1s and 2s that resolve when they're now 40, 50 years old? Are those patients who are coming in with, late onset, adult UPJ obstructions? Are those patients who develop renal insufficiency over time? Or is there no good data on that yet?
I think that, so the literature that got to those resolution points that are like 5 years out, because they followed those children to try to understand like how long would it take a grade 2 to resolve. I think the follow-up time period was probably like a median was closer to 10 years. So they were following a lot of patients for a long period of time. I think that was a single or like kind of small multi-center analysis, but I don't know that there's any data on like adult representation for, kind of prenatal hydronephrosis diagnoses. So that's challenging because I think there's like kind of these inflection points where you might see a patient with like a UPJ obstruction, but they may not have been diagnosed in infancy. Like there's just a lot of loss of information, particularly in the prenatal to postnatal period. But that's a food for thought to try to figure out if we could find those patients.
Yeah, just from the sense of, is that something that goes into the parental, family counseling?
Right.
Hey, this is resolved, but, in the future need to be monitored or, followed more closely than someone who didn't have prenatal hydro. Just curious.
Yeah, thank you.
All right, well, thank you, Dr. Cannon.
Thanks, guys.
Yeah.